Good morning, and thank you for the invitation and as well to consider surgeons in this multidisciplinary approach. Briefly, we're going to go through why is the surgeon involved and diagnosis and treatment and the vascular and bowel options. So the main reason why surgeons are called, and it's been also mentioned in the previous presenters, that it's the abdominal pain. So we are normally asked to see patients because they have pain and to rule out the different differentials. Mainly what we consider are, of course, the onset, but as well, particularly when the pain is in proportion to the physical examination findings, and we start considering that might be acute ischemia. Another frequent reason why we're called to assess these patients are patients in the ITU or patients in the resus bay that are severely ill, where they might think the abdomen could be the cause. And of course, this has been mentioned as well. Lactate, when we are looking at lactate, is actually probably in a very late state, and because the AMI with transmural infarction is the one that's going to show us with more lactate, but remember that ischemia starts in the mucosa, and therefore all these new biomarkers are quite promising because they are the ones that are starting actually on the mucosa. Regarding prognosis, that we're always asked as well, like what's the prognosis of these patients at that point? Probably is guidelines are not so clear about that, but it's difficult to prognosticate exclusively on clinical findings, even though we know that older patients with delayed presentation and abdominal signs of peritonitis probably would have a worse prognosis. The different scoring systems, especially P-POSSUM score and Apache score, has not been have a good correlation with mortality for these cases. So we consider these causes as well when we're talking about acute ischemia. And of course, we would take the onset and the background of the patient for embolic, which is the most common one, and the thrombotic, especially if there have been some procedures been done, and the non-occlusive states when we have someone post-arrest, for example, or being vasoconstricted by use of cocaine or other vasoconstrictive drugs. Another reason why the surgeon is involved is to assess images that have been requested by maybe another colleague or another specialty. And we normally have an image where they show us the side of the block and as well the state of the bowel. But as you know, better than me probably, the images for bowel are not exactly so reliable, especially at the beginning of the condition. So we have different reasons why we can have a blockage, so embolic, thrombotic, or low flow, but regardless of the reason, we're going to have a hyperperfused bowel. So basically we can divide these into problems. So we have a flow problem and a bowel or perfusion problem. So the role of the surgeon will be then in reestablishing flow and as well on bowel assessment. So for establishing flow, it's important to consider the mechanism, therefore if it's embolism or thrombosis, because these are the main two where surgery seems to have a bigger role. Another thing we consider is as well the height or the site of the blockage, and we use these classifications done by Fullen. We use it mainly for trauma, but can be useful in this case, as we know that in the first two zones are the ones where we have much more repercussion on bowel, and that's probably because we have much more rich collaterals distally. Basically, then surgery would have a higher role on the first two zones. And what do? We start by doing vascular exposure. There are different ways to do that. This is the anterior one, where you would follow the mid-colic until you get to SMA, and you would isolate it, or you would have the lateral one, where you would divide the triads ligament and then access the aorta from the side and identify the AMA, probably a very common access as well. This is how it looks in real life. And this is another way to expose the AMI, the SMA, sorry, but we normally keep this one for trauma because it's the left medial visceral rotation, which carries much more morbidity on its performance. So the procedures start with therapeutic heparinization, proximal and distal control, transverse arteriotomy. Rarely we use a longitudinal arteriotomy and a closure with the graft. And then we put the Fogarty catheters proximal and distally to remove the clot. Then we flush it and we close the arteriotomy. So this could be, it's an alternative to endovascular, and it should be decided which technique would be better based on the capabilities and the resources locally. But if you find if you find that this embolic when you're assessing in a laparotomy, then probably it's a good idea to complete the treatment by removing it. An option for thrombotic, where we have, which is less common, would be to do the bypass, as has been mentioned. And there are two ways to do the bypass. It's proximal or anterograde, which is where the flow is coming proximal to SMA, or distal, where the origin would be distal to the SMA, which is a retrograde one. Another option is the retrograde open mesenteric stenting, which is like a combination of having an open access but with an endovascular procedure. The recommendations of the European Society of Trauma and Emergency Surgery are that when a bowel integrity has not been compromised, endovascular techniques should be performed first line for thrombotic ones. And when a laparotomy has been done for it, then the choice of intravascular intervention would depend on the resources. For venous and non-occlusive, then there seems to be less role for surgery, even though there might be some role for interventional radiology in the VAMI for reperfusion. And regarding bowel, as we said, regardless of the cause, you can have bowel ischemia, and therefore there's role for surgery in any of the mechanisms of bowel of arterial occlusion. And we can do that by laparotomy, which is the preferred cause, the preferred method. Laparoscopy has been described. However, if it's positive, it's fine. But if it's negative, you might miss the reason where there's some ischemia, which you can. So it's not the preferred way to do it. And you can also decide, of course, not to do it. And what do we do in laparotomy? We assess the bowel microscopically on how it looks, but how it moves, and if you have bleeding ends. You make a resection. You never do anastomosis in these cases. And you would take the patient back to the ICU for resuscitation. If all small bowel is necrotic, again, it depends on the reason and the stage of the patient and your local capabilities. Patients then left with the open abdomen to come for a second look where you might perform your anastomosis. Thank you very much.